Bismillahirrahmanirrahim. In this video, I will speak about oxygen therapy. Oxygen therapy is the use of oxygen as medical treatment, and acute indications for oxygen therapy include hypoxemia, which means low blood oxygen levels, and indications of emergency autotherapy of oxygen is classified into uncontrolled and the highest level thought to be important, such as shock, sepsis, major trauma, cardiac arrest and during resuscitation, anaphylaxis, carbon monoxide or cyanide poisoning, pneumothorax, and the second category is uncontrolled and auto saturation values between 94 and 98% are thought best, such as in pneumonia, asthma, acute heart failure, pulmonary embolism. And the third classification is controlled use when extra oxygen is required but ventilation critically depends on hypoxic drive, in which we recommend auto saturation 88 to 92%, such as in exacerbation of COPD and exacerbation of cystic fibrosis and exacerbation of ventilatory failure due to obesity hypoventilation syndrome and exacerbation of chronic ventilatory failure due to scoliosis, neuromuscular disease, and any other cause of pump failure. Now we will go to home oxygen therapy. Home oxygen therapy was originally prescribed under three clear headings. First, long-term oxygen therapy, in which we use oxygen more than 15 hours per day. And second, short burst oxygen, in which we use oxygen to cover periods of shortness of breath, such as after exercise. And third, ambulatory use of oxygen to allow activity with less dyspnea. Benefits of long-term oxygen therapy include reduction of secondary polycythemia and improved sleep quality by reducing hypoxia-associated brain arousals and reduced cardiac arrhythmia and potentially reducing the risk of nocturnal sudden death, reduced symptomatic outflow, leading to improved renal function with increased salt and water excretion and reduced peripheral edema. Indications of long-term oxygen therapy, as we said before, long-term oxygen therapy is the provision of oxygen therapy to patients with chronically PaO2 below or equal to 7.3 kPa or below or equal to 55 millimeter mercury, or saturation below or equal to 88% for more than 15 hours a day, to include the right when usually most hypoxic, with the aim of achieving an awake of PaO2 more than 8 kPa or more than 60 millimeter mercury, or saturation more than or equal to 91%. PaCO2 levels can be normal or raised. Indications to which Long-term oxygen therapy now covers are chronic obstructive pulmonary disease (COPD), severe chronic asthma, and cystic fibrosis, bronchiectasis, pulmonary vascular disease, pulmonary hypertension due to pulmonary cause, and pulmonary malignancy, and chronic heart failure. Assessment of long-term oxygen therapy. We assess when patients are stable and more than 5 weeks have passed since any exacerbation of their condition, and fully optimized treatment, and two sets of arterial gas are taken at least 3 weeks apart to ensure that the patient remains sufficiently hypoxic to merit long-term oxygen therapy. The blood gas are also taken after 30 minutes on supplemental oxygen to ensure the target of PO2 has been reached. Now we'll go to some practical issues of oxygen therapy regarding home oxygen. Home oxygen should not be supplied to patients who still smoke due to added fire risk and probable reduced efficacy due to increased carbon monoxide hemoglobin. Long-term oxygen therapy is provided by an concentrator set between half and 8 liter per minute, and some concentrators can deliver 8 liter per minute. Concentrators contain a molecular sieve of zeolite which traps gas molecules depending on size and polarity. Patients may have a higher flow rate for use during activities. Patients can use nasal bronchs or a fixed concentration mask. Uncontrolled or controlled oxygen, as for example 24% and 28%, depending on physiological requirements and their preference. A backup cylinder should be prescribed in case of power cuts. Oxygen humidification cold is possible but rarely necessary or effective. Tube lengths of below 1.5 meter recommended. Long-term oxygen therapy should be used for more than 15 hours per day in patients with COPD, although survival improves when used for longer. Therefore, use should not be restricted to 15 hours per day. Patient education in the use of long-term oxygen therapy and the machine maintenance is important. Specialist respiratory nurses should be involved with this. And if using short burst oxygen therapy at 3 oxygen cylinders a week, an oxygen concentrator is more economic. Now we will speak briefly. Now we'll enumerate some oxygen devices. Oxygen devices include face mask, which may be simple face mask, or non-rebreathing reservoir masks. And there is nasal cannula, nasal bronch, nasal catheter, and there is Venturi mask, and there is CBAB and BiBAB and Ambu bag. At the end of this video, we should refer to auto alert card, which should be given to all patients with a previous episode of hypercapnic respiratory failure. This alerts ambulance crews and medical staff to the potential risk of hypercapnia with very high flow oxygen and documents usual resting baseline saturation of oxygen. However, some ambulance staff protocols are sufficiently rigid that they may not be allowed to override them. In some areas, letters from patient's consultant and the head of ambulance service must be with the patient. I hope this video is beneficial. Goodbye with my best wishes. Thank you.